Good afternoon, everybody, and thank you, Tito, for introducing me. My name is Dr. Friedemann Schad from Berlin, from the Gemeinschaftskrankenhaus Havelhöhe. And I thank the organizers for inviting me to give a short impression of our work. And I prepared some figures, some graphs, and some pictures, which I would like to share with you in the following 15 minutes. The Gemeinschaftskrankenhaus Havelhöhe is an acute hospital, and we are a primary and regular care hospital involved in the landscape of hospitals in Berlin and well established in the German health insurance system. Sometimes it's important to emphasize this at the beginning. Here you see our departments. In the first two slides, I just want to introduce a little bit our hospital. We've got about 400 beds, and our staff is more than 900 members. A third of those are in full-time, the rest is part-time, 170 physicians, and more than 300 nurses, basically. We have quite a large internal ward, with gastroenterology, with cardiology, with oncology, with pulmonology, and with quite a large aspect of intensive and intermediate care. And I was asked to give you an impression how we treated COVID-19 patients in the intensive care units. To close our presentation of our hospital, some figures, just that you have an impression. The average of hospital duration stay is 7 days. We treat about 13,000 patients a year. We've got 3 cardiac catheter lab, inclusive EPU. We have got quite a high volume endoscopy department, both in gastroenterology and pulmonology, and in the interdisciplinary tumor board of our oncological center. We see more than 2,000 patients in the tumor board. Now, anthroposophic medicine, it has been said already by Tito, is always grounded on the natural science-based medicine. But we have the privilege actually to add and to contribute to this a integrative concept out of anthroposophic medicine, which includes natural remedies, but especially includes a lot of non-pharmacotherapeutical interventions, NPIs. Probably many of you have known this. And doing so, the aim is always also to individualize this concept onto the patient's perspective. 2 figures on COVID in Berlin. Here you see what we call always the first and the second wave. This is the April from last year, the summer from last year, and then coming up in the autumn starting in October 22. The figures of all patients treated in Berlin hospital in general. We have about 52 hospitals in Berlin. And the blue line are those who have been treated on peripheral wards. And the other lines are treated in ICU units or have been ventilated. Or the baseline here are those patients who had been on an ECMO treatment, extracorporeal membrane oxygen therapy. So these are the Berlin figures. You see there are about 1,200 was the highest time at the beginning of January this year. If you see in our hospital, these are the figures from our hospital, but starting in October, going up. The blue lines are those on peripheral wards, which with the highest point were more than 30 patients. The other lines are our treatments of COVID patients in the ICU. And those lines are those who have been ventilated or needed ventilation therapy. A part of 8 patients in the whole we had who get the ECMO therapy as well in our ICU. Just some impressions. This is a morning ward round. Nurses and doctors do this together. And most of our patients had tracheostoma, was needed for long-term ventilation. And of course, there's also a lot of technique around on an ICU, as you see, and as you know, dialysis, ECMO, and ventilation, of course. Now it's quite demanding in turning patients around. In preparation of this, in doing so, it needs to be done carefully. And actually, we need 6 members, 6 staffs who do it. And having a lot of ventilated patients, this is really a psychologically and bodily, physically strenuous work. Of course, as the statistics say, many of the COVID patients had been having risk factors. Here you see a patient with a destroying COVID lung disease and adipositas, as you can see already in the X-ray, with a quite bad lung, and there you got the CT. Just to give an impression, which COVID patients also we did treat during that time. The peripheral ward was established in the gastroenterology department and infectiology. We treated more than 200 patients in this ward. Maybe you have seen these pictures in your hospitals as well. It's quite an organization to manage it for the staff. And here everybody has his personal mask, of course. Everything needs to be disinfected. You have seen this in other hospitals and other circumstances. It's quite important to manage it for the team on 3 duties, even on night duty. Manage this all together with the team. Now, this is a colleague of us just starting the ward round. And there was one very important thing on the treatment of COVID patients. It needs time, it needs attention, it needs relation, especially in those who have been treated and who are awake and who are short of breath in the peripheral wards. So we established in the last half a year, we established an additional duty round on weekends to have enough time for the patients. And apart from the organization to do all this hygienic stuff, especially to have time for the patients and to talk to the patients, this had a major impact. Standards of care. Here I just want to mention the head of our emergency medicine department, cardiology intensive care, Dr. Fabrizio Esposito, who actually takes it all on his shoulders, what I tell you today. The standard of care, many of you know that. We follow these as well. Heparin anticoagulation quite early, dexamethasone, referring to the recovery study, CRP apheresis. In case of dialysis, we use the cytosol filtration. All these managements have the aim to reduce the inflammation, isn't it? And colchicine, I mentioned in another slide later, which we already use and also use now in treatment of ICU patients. ECMO, I have already mentioned. And we are involved in one study together with Charité here in Berlin on a apheresis, CRP apheresis treatment with the aim to reduce the inflammation storm in the blood. The anthroposophic concept, which is the topic of today, I wouldn't go too much into the details because I assume the colleagues after me will more focus on it. Basically, I can say that on the ICU, but also in the peripheral ward, there's a broad standard of anthroposophic remedies we do use, in the acute phase or in the recovery phase. And if anybody is interested, there has been a summary of all these treatment suggestions, actually, and one can look it up at the antromedics.org. You can see here, which had been published by Thomas Breitkreuz. I'm sure he'll mention it later on as well, and Georg Soltner. Every of our hospitals developed his own standard, and it was actually put together in these suggestions. Pneumodorone, Pertodorone, Ferrumsiderum, Pronus, Leviquocomp, basic anthroposophic remedies. Used additional to standard of care. Another column of anthroposophic medicine, an important column, are the nursing interventions. You may have heard of that. There are wrappings or ointments or foot massage, which we use, and is really a therapeutical issue done and managed by the nurses, and has a major impact in our treatment. And we have a very good experience in daily care, in reducing anxiety, in giving care to short breathing patients, even in patients who are very weak after these high fever phases in the early treatment. And that is actually established in our 2 wards and does help quite well. I want to mention and focus also on the psychological support. As I mentioned already, in our wards, it takes time. Patients need time to talk about their anxieties and their hopes. And that's why we even established additionally a psychological ward at the weekend, ward round, also on the ICU unit. The psychological support comes from our Department of Psychosomatic Medicine. And as long as people are not ventilated and are awake, it's a great help doing so in the ICU context. Called Corona is a quite large study with over 4,000 patients from Canada. Here is the citation, Tardif et al. And I just want to mention it because it's a suggestion of a treatment. You start 3 days with 2 times 0.5 milligram. Then the study was done following this introduction with another 4 weeks of 0.5 milligram per day. And the study was telling quite impressive, a reduction of hospitalization, of pneumonia, of ventilation rate and death. Now we have done experiences with 9 patients, and it's astonishing, positive, our experience, especially in recovering of the pulmonary symptoms. There have been data which don't support this positive effect of colchicine, but we think probably because of the time when it's used and because it reduces the inflammation and the proliferation of lymphocytes, probably it's advisable not to use it at the very, very first or to use it late, but to use it in the face of the starting inflammation response. Watch side effects, that's true. Gastritis, diarrhea, vomiting has to be addressed. There's an overview of our figures and numbers, and I just lead you through very shortly. In the whole, we treated 276 patients with COVID in our hospital. 52 of those have been treated on the ICU, more than 200 in the peripheral ward. The age, in average, was 73. I thought actually that they're more elderly patients, and that was last April the case. But in the last months, their patients become younger. The duration of stay in the ICU is 39 days. and the duration of ventilation, if you are ventilated, is more than 900 hours, which comes down to 37 days ventilation in average, which is quite long. Imagine that. Well, 8 patients on ECMO, but ECMO takes very long. We see that in other hospitals in Berlin as well, summing up to 150 days of ECMO treatment. 22 of those 52 were released. 30 patients died. Today, we've got 8 patients on the ICU and 4 patients in the peripheral ward. And it comes down to a death rate of 17% in our collective, in our patients in the whole, up to now. My last 2 slides, I want to focus on how important it is to communicate, how important it is to give information to the staff. So we established in central management, any department was involved, technical issues, facility management, public relations, to decide together what are the standards. And of course, we had a crisis team. Then we established a morning round weekly, a newsletter weekly to inform the staff, because it is strenuous to treat COVID and COVID-19 patients. And we established some offerings, for example, a program on resilience. And our co-workers can involve themselves during the week in different offerings like yoga, like movement therapy, like mind-body interventions and others. Because many of the people had the questions, did I went COVID, but I didn't know it. So we had antibody testing as an offering, and almost everybody did it. 90% of our staff did it. And since we are able to offer the vaccination at this beginning of this year, now the vaccination rate in our staff is 55%. Last slide. In treating COVID-19 in our hospital, of course, we are based on a high excellence in intensive care and treatment of infectious disease. But the multimodal approach of anthroposophic medicine seems to be very helpful. Nursing applications, supportive natural remedies of anthroposophic basis. Psychological support is very important. Have time for the patients, and transparency and information motivates the staff. Coming to an end, maybe it's important to say, to support the feeling of trust and care and attention in patients, but also in professionals. So thank you very much, and I hand back